Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This episode is part of our series on sleep and mental health. The content here is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. Once sleep medicine stopped trying to sedate the brain, the question became more nuanced. How do we support sleep without destabilizing cognition, mood, or physiology? That question defines the modern era of sleep pharmacology. These agents are not about knocking patients out. They are about targeting specific components of the sleep-wake system with fewer downstream costs, especially in patients with psychiatric comorbidity. We have already talked about orexin antagonists, which reduce wake drive. The remaining modern agents fall into three broad categories: circadian modulators, selective sedative adjuncts, and repurposed psychiatric medications, each with very different risk-benefit profiles. Second, selective sedative adjuncts. What psychiatry often reaches for next. Low-dose doxepin is a key example. At doses of 3 to 6 milligrams, doxepin functions primarily as a histamine or H1 antagonist rather than an antidepressant. This distinction matters. At these low doses, it improves sleep maintenance with minimal anticholinergic burden and little effect on REM or slow-wave sleep. This is very different from using higher-dose sedating antidepressants as sleep substitutes. First, circadian modulators beyond melatonin. In addition to what we have talked about earlier, newer formulations of low-dose melatonin and time-release preparations are being studied with more precision. The emphasis is no longer on dose escalation, but on timing and phase shifting. In the right patient, delayed sleep-wake phase, ADHD-related circadian drift, or mood disorders with late-night activation, these agents can stabilize rhythm without impairing daytime function. But again, they do not override hyperarousal. Which brings us to the third category: repurposed psychiatric medications. Trazodone is a serotonin antagonist and reuptake inhibitor, or SARI, dosed at 25 milligrams to 100 milligrams. It is the most common off-label choice. Higher doses of 150 milligrams and above moved into antidepressant territory. Quetiapine, a second-generation antipsychotic or SGA, is usually dosed at 12.5 milligrams to 50 milligrams. This is subtherapeutic antipsychotic levels, but used for antihistamine effect for sleep. We still need to monitor a metabolic profile. Mirtazapine, a tetracyclic antidepressant, classified as a noradrenergic and specific serotonergic antagonist, or NASA, is dosed at 7.5 milligrams and 15 milligrams. Paradoxically, it is more sedating at lower doses due to potent H1 antagonism. Hydroxyzine is a histamine 1 antagonist, dosed at 25 to 50 milligrams. It is often preferred for anxious type of insomnia. Gabapentin, a gabapentinoid, is dosed at 100 to 300 milligrams. It is useful for maintenance insomnia or sleep disturbed by restless legs or neuropathy. Amitriptyline, a tricyclic antidepressant or TCA, is dosed at 10 to 25 milligrams. It is effective for sleep maintenance but carries high anticholinergic burden. We need to monitor its use in the elderly. The drugs we just mentioned are off-label agents that are frequently used for insomnia, not because they treat insomnia, but because they cause sedation. And this is where modern sleep medicine draws a hard line. These medications alter multiple neurotransmitter systems simultaneously, serotonin, dopamine, histamine, alpha adrenergic pathways. The sedation is real, but so are the costs. Metabolic effects, orthostasis, QT prolongation, anticholinergic burden, emotional blunting, and next-day cognitive impairment. From a sleep architecture standpoint, these agents do not reliably restore physiologic sleep. They sedate, they fragment, they create dependence on chemical sedation rather than sleep regulation. In patients with severe psychiatric illness, there may be narrow justified use cases. But for primary insomnia, these are not modern solutions. The defining feature of modern sleep agents is specificity. Orexin antagonists target wakefulness, melatonin agonists target timing, low-dose doxepin targets histaminergic arousal. None of them retrain behavior. Medications can lower the barrier to sleep. They can reduce nocturnal alertness. They can stabilize circadian signals. But they cannot unlearn conditioned wakefulness. They cannot correct maladaptive sleep behaviors. They cannot resolve this fear of not sleeping. That's why even the most advanced agents plateau in effectiveness when used alone. Modern sleep medicine is not anti-medication. The right drug for the right mechanism in the right patient, paired with behavioral treatment, that's where durable outcomes live. And that's where this series now turns. Because the most modern treatment for insomnia is not new. It has just finally being used correctly. That's all for this series. However, we have added an episode on decision tree to tie up all the sleep agents we have talked about. If you found this series helpful, please share it with your colleagues across disciplines. See you next series.